Hi, good afternoon, everyone. Thank you for attending today's Meaningful Use webinar. I am Lori McAleer of the Health Collaborative, and I will be today's moderator. Before we get started, there are a few things that I want to notify you of. First, we will mute all lines and ask that you type any questions in the chat box located in the lower right-hand corner of your screen. After the presentation, we will have time for questions and will answer as many questions as possible during today's one-hour session. Today's webinar will be recorded, and a PDF of the slides and other resources referenced in today's presentation will be emailed to you in the next few days. Also, if you haven't already done so and you've called in, please be sure to mute your phones. As you know, meaningful use reporting requirements continue to change, and this one-hour webinar will tell you what you need to know for the 2015 reporting period and for meaningful use attestation. I am happy to introduce today's presenters, Scott Pettigrew and Wendy Bridges. Scott has been involved with the Tri-State Regional Extension Center, which is part of HealthBridge, since its beginning in 2010. He is the meaningful use subject matter expert for the Health Collaborative. A side note, many of you may have worked with the Regional Extension Center in the past and know that it was part of HealthBridge. Last year, HealthBridge joined the Greater Cincinnati Health Council and the Health Collaborative as all three organizations came together as one. The Health Collaborative name was kept as we collectively work together to improve health and healthcare in the Greater Cincinnati region. We are also joined today by Wendy Bridges, a consultant with the Regional Extension Center who helps practices achieve meaningful use. Scott will do most of today's presenting, and Wendy will chime in with nuggets of information from her work in the field. One other note, in the interest of brevity, most of this webinar's information is geared towards what eligible professionals need to know about 2015 meaningful use reporting periods. However, much of this webinar's content also applies to and will be helpful for eligible hospitals and critical access hospitals. Where necessary, we've made clear what applies to EPs and what applies to EHs and critical access hospitals. To help answer the question of what eligible professionals, hospitals, and critical access hospitals need to know about the 2015 meaningful use reporting requirements, I will turn it over to today's primary speaker, Scott Pettigrew. Scott?
Thank you, Lori. Appreciate it. Good afternoon, everybody. It's now afternoon, and glad to see everyone on board. I'm seeing a lot of familiar names, but a lot of you I haven't met yet, so welcome, and hopefully you'll find this webinar helpful as you get ready to attest for meaningful use and as you kind of close out your meaningful use reporting period here in 2015. Also with me is Wendy Bridge. Wendy, are you unmuted and able to speak?
I believe so. Can everybody hear me?
Absolutely, we sure can. Thank you very much for joining me, Wendy. And thanks for bringing your in the field. Go ahead.
Glad to see so many familiar names on here. Hope you all get a lot out of this today. Scott will teach you everything you need to know.
Wendy, if you have anything to say, just kind of chime in, and hopefully I can hear you and can stop. And if I don't, send me a message, and I will definitely do so. All right?
Okay, great.
All right, and with that, let's get started. I'm going to start off with a very brief background into meaningful use and kind of what got us here. I'm not going to dwell on anything for too long because we have a lot to cover. This is a dense webinar. We will be making all of these slides available after the webinar, so you don't have to frantically keep notes, and we'll also be providing links to some very good resources provided by CMS, which is the definitive source for this material. So ancient history, when by ancient history for meaningful use we're talking about 2009, that was when the American Recovery Reinvestment Act, ERA, was signed into law. And part of this huge stimulus bill was the EHR incentive program, and it was billions of dollars designed to help providers offset the costs of EHR selection and implementation, and this was going to be divided among three different sources. Number one was going to be eligible providers. These are your primary care providers that are doing the bulk of the medical care in the country. Number two would be the eligible hospitals, and these are just any hospital in the United States that would was going to be using certified EHR technology. And the third was critical access hospitals, and these were a very specialized subset of more rural and critical care hospitals that were getting some special treatment within this bill. The bill provided incentives which were set up for meeting and maintaining certain levels of utilization, stages of meaningful use. And the whole bill was designed so that you started off easy with kind of what I call Meaningful Use 101, which was basic implementation, running reports, making sure that you were used to putting things into the right places into this EHR technology so that you could do things with it later that would benefit the patient and also the doctor as you went forward in your medical relationship and your healthcare relationship. Things like putting drugs into the system so that when you prescribed a drug for a patient, it showed up that they were receiving that drug. Once you do that, then you can ping that for drug interactions, allergies, things of that nature. So all of these things had to have a level of usage at the EHR level for the provider of care. And so that was what kind of stage one was set up for. Stage two is set up to kind of move forward, start some interoperability, and continue that towards a more connected healthcare environment so that you could check and communicate with your provider via their web portal, for example. And then stage three and beyond was set up to further those goals even more. So part of that bill, part of ERA, also set up the regional extension centers. These were 63 separate centers set up across the United States designed to really assist eligible providers and the different hospitals in, number one, selection and implementation of their EHR technology, because before that point, 50% or more of EHR implementations failed, and they either stopped using the EHR or were having to rip and replace, which is a very expensive, not only in money, but also in time and resources for these practices. It was just a huge burden. So the Tri-State Regional Extension Center was one of 63 nationwide, and we were covering the entirety of the Cincinnati area, including where Cincinnati's medical service area reached into Kentucky and east and southeast Indiana. So I've been with the Regional Extension Center since 2010 and helping a lot of you reach meaningful use since that time. Just a reminder, please, if you're sharing your video, if you would turn that off, that would be wonderful. So to this year, so stage two of meaningful use was scheduled to begin in 2015, but it was becoming very, very clear that there were problems. Providers were having problems meeting implementation deadlines, and by providers, I'm talking about the EHR vendors and the practices were both having problems meeting implementation deadlines. And also, the EPs, the EHs, and the CAHs were all having problems meeting the new objectives and measures, oftentimes because of very poor implementations of the EHR technology. Bugs, things simply were not working, and to be honest, in some cases, the goals were, I think, a little lofty in trying to get some of these technologies out in the field, especially when you were talking about some of the interoperability and some of the secure messaging. So it was becoming very clear that the EHR incentive program's underlying goals were in danger of not being met, of this becoming an even bigger problem. So changes needed to be made. So earlier this year, March of this year, we received notice that the Notice of Proposed Rulemaking, the NPRM, for Stage 3 was released. But they, at the same time, they kind of telegraphed to RECs and to people that were kind of close into ONC and CMS that there were going to be some large-scale changes to Stage 1 and Stage 2, and to kind of hang tight, and they were going to address these things. And on April 10th, that actually did happen, and an additional NPRM outlining large changes to these to Stages 1 and 2 were made. As some of you may know, there's a very specific order of events that happens when an NPRM is released. There's a 60-day comment period, and you can't bypass that, after which they have to reconcile those comments and then make the final ruling. Well, we were expecting that ruling to come out sometime in August or September. They had parroted fall, so we were hoping for September, and we didn't actually get it until October 6th, which unfortunately, the problem is, that was after the final 90-day reporting period for 2015, and this has caused some consternation. But we'll talk about that in just a bit. There were very large changes to Stage 1 and 2 for 2015 through 2017, and the Stage 3 final rule was also released with comment period. So there still is some time to make some comments on Stage 3. So do go back and take a look at Stage 3 and see, if you haven't read that, it is worth a look to see what's coming in the future. So that brings us to where we are today. So what are we going to do with it? So the EHR reporting period changed. In 2015, all reporting periods are calendar-based. This is critical access hospitals, eligible hospitals, and eligible professionals. Now, it's all calendar-based, January 1 through December 31. This means that eligible hospitals are going to have to make a little bit of a change, and I'll cover that in just a second, so just hang tight. I know that that's a red flag. Eligible professionals, the 2015 EHR reporting period for 2015 only is any continuous 90-day period. So valid start dates start on January 1st, 2015, and run through the last start date you can have is October 2nd of 2015. It's not linked to quarters or months as it was in years past, where during the 2014 it was linked to quarters. It's not that way this time, and it's not linked to months as it is if you do AIU for Medicaid. It's not linked that way at all. So you can start on July 10th if you want to, any 30-day period. This is just any 90-day period. This is just like the first year of meaningful use. If you went through Stage 1, your first year was exactly like this. Back to eligible hospitals and critical access hospitals, you're switching to calendar-based year as well, but because your previous reporting cycle was based on fiscal year, for the 2015 year only, for meaningful use 2015, you can select any reporting period between October 1st and December 31st. So your start dates can be between October 1st of 2014 and October 2nd again of 2015. All right, and again, that's a continuous 90-day period. Let's talk about deadlines. These also changed with the meaningful use final rule. Reporting periods for 2015, again, continuous 90 days cannot extend beyond December 31st. But the systems that you'll be reporting to for Medicare will only become available January 4th. So you can't, even though you may be attesting for a reporting period starting in March and ending in June, you cannot attest for that yet. So you're going to be waiting until 2016, January 4th. As you can imagine, there was a huge number of changes that needed to be made to the reporting portals, both at the federal level and the state level. By the way, I do want to talk about that for a second. And the reporting will be by attestation again in 2015, and you'll be doing it in the same manner that you were doing it in years past. So you'll be going out to the federal attestation website, and I will be providing those links in a sheet that you'll receive in the next couple of days. And for Medicaid, you'll be reporting via your state Medicaid websites as well, again, just as you did in years past. Medicare providers must attest for 2015 reporting periods by February 29th. So we can't go beyond that 60-day reporting period. And it's really not even 60 days, right? So you do need to be on the ball, and you do need to have everything, all of your ducks in a row, and be able to attest prior to February 29th. I really wouldn't put that off. if you've done this in the past, you know how these systems miraculously go down on the first and last days of these reporting periods. So, you do want to be ahead of the ball on this one, be ahead of the 8 ball. And I don't anticipate them extending this, barring any huge issues with the systems. So I would recommend doing your attestations 1st of February at the latest, starting that process. Privacy and security audits, still required. They should be conducted during 2015. They must be completed prior to the end of the reporting period, but they may be started prior to the beginning of the reporting period. So if you do a privacy and security audit prior to March 31st of 15, if you completed that in the first part of the year, that would be valid for all reporting periods in 2015. If you have not yet done your privacy and security audit, this will severely limit the number of reporting periods, how you can shift your reporting periods if you need to in order to meet these measures. So I've been saying for a long time to a lot of my practices, get these done early in the year rather than later. There is some question as to whether or not a reporting period that was done, a privacy and security audit that was completed in December of 2014 would count for the 2015 reporting year. My best advice to you, and I'm a part of the Meaningful Use Burning Issues group, and we've been talking about this issue now for 3 weeks because this was brought up in one of the webinars. There's conflicting information out there, and if you want to survive audit, my recommendation is do a privacy and security audit in 2015 for the 2015 reporting year. Some overall changes to meaningful use. Again, a lot of changes to meaningful use. They have combined stages 1 and 2 for 2015, 2016, and 2017. This is in preparation for 2018 and beyond, rather, when there will be no stepping up stages of meaningful use. Meaningful use will be a single monolithic item. It's going to be what stage 3 is, will be all that there is for meaningful use after 2018. So good to get in on the ground floor, good to get in while you can actually still work on these skills in this kind of stepped paradigm. Also, all providers must be using 2014 edition certified EHR technology, and that must be installed by day 1 of your reporting period. So go back, make sure that you're on 2014 edition EHR technology, and understand when that was installed, because you may not start your reporting period prior to that install date. If you do not have 2014 edition EHR technology installed by now, unfortunately, you will not be able to attest to meaningful use for 2015. That's a very important thing to understand. And if that's the case, and I don't think it is for many of you anymore, if that is the case, you should be talking to your vendors very loudly, very quickly, to make sure that's in place for 2016, because 2016 is a full year attestation. Some high-level changes to the objectives and measures, and this is for the for eligible providers. Whereas before we had core and menu set measures, core were required and menu set were kind of like you could take 85 out of the 10. Now we have 10 required objectives and measures associated with those objectives. All 10 are required, but some of the measures do have exclusions and ways that you don't have to meet them. Also included in those 10 is one public health reporting objective. That public health is reporting objective we've seen before. This is like the immunization registry reporting, syndromic surveillance registry reporting. And again, not all of these measures must be completed. Even in the public health reporting, in each measure has possible exclusions. For eligible hospitals and critical access hospitals, you now have 9 required objectives with associated measures. and again, one public health reporting objective. Again, all 9 are required, but you do have ways that you can get exclusions. Also, each of these objectives and measures, not each of them, but many of them, have alternate exclusions and specifications. And the reason this was done was because this was released so late in the year. CMS realized that if they had changed some of these specifications for 2015, nobody was going to be making meaningful use, or very few. So this is a way to allow the providers that were previously supposed to be on stage 1 to not have to step up to meet the more stringent measures required of stage 2, which is really what the combined measures are. They're kind of forcing everyone up into stage 2. Now, there's 2 ways that they're doing this. Number 1, they're using a lower threshold for certain measures if you were scheduled for stage 1 in 2015, and those will be called out. Now, I may not be able to call them all out here during this webinar, so we will be providing links to the specification sheets, and on those specification sheets, these are kind of like your Bible when it comes to meaningful use specifications. I carry them wherever I go when I'm out in the field, because these are the definitive answers. These use quotes from the rule, and they are actually, you can refer to these in Audit because they are a specific publication of CMS and ONC. Now, the second way that you can, that they're kind of reducing the workload for 2015 is they allow you to take exclusions for measures for which there was no stage 1 equivalent. So if you're seeing something on there and you're doing stage 1 and it wasn't there in stage 1, you are probably going to be able to say, hey, I'm supposed to be on stage 1, I can just opt out of this measure. So don't panic, just kind of keep those things in mind as we go. So a couple of things to keep in mind. A number of the measures and the objectives that we've talked about in years past in stage 1 and 2 have been removed from the modified stage 2. These are things like the demographics, the race, sex, ethnicity, and language. And my programmer self is seeing a parenthesis is not there, and it's setting off my OCD. Record vital signs, height, weight, and blood pressure, smoking status. You can read the list. I don't need to go through the whole thing. All of those have been removed from meaningful use. But please don't stop doing these things. One of the little tricks that CMS and ONC did in creating the new stage 2 and also stage 3 is requiring these items. So when you send out a summary of care document, a CCDA. A CCDA is not a CCDA unless it contains some of these items. So please do make sure that you are still doing these, what I call foundational behaviors for meaningful use. Make sure you continue to do them. Image results, that's not a part of that. Family health history is not necessarily a part of that. Definitely demographics, vital signs, smoking status. Please make sure that you are still doing those for every patient. Wendy, have I missed anything so far, or have you been trying to kick in? Oh, okay.
I guess you got it covered.
All right. So before we go any further, I do want to apologize to our listeners who are from eligible hospitals and critical access hospitals. From here on out, I'm really only talking about eligible professionals. However, at the end of the webinar, there are some links that will send you out to the specification sheets for eligible hospitals and critical access hospitals. And I do urge you to stick around, listen to these, because you may be dealing with some providers out in the field that are working on these measures, and some of them require communications for referrals, and for sending CCDAs on transfers of care. So I would urge you to keep listening so that you understand where your providers in the field are coming from, even though they may not directly apply to your hospital. I know a lot of you also are liaisons between hospitals and your associated eligible providers, so these will still be helpful for you. but I'm not going to go into a lot of detail on these. We're about 25 minutes into the call, and I do want to leave some time for questions, so I'm going to kind of breeze through these pretty quickly. The first thing out there we've talked about already, so we're going to go through the 10 eligible professional measures, and objectives and measures, and the numbered items on these are the objectives. These are the 10 required items. Where you see a check mark underneath it, these are separate measures that have to be met. For these items, unless you have a specialized exclusion, you have to meet all of the check-marked items underneath in order to be able to claim that you have passed the measure. That's very important to understand. If you fail one of them and don't have an exclusion or don't have an alternate measure, then you will fail that objective of meaningful use and will not be able to attest to meaningful use for that reporting period. Now, again, remember, with 90-day reporting periods, you can slide things around. You can change your start and end dates, and that can actually change your meaningful use percentages. So if you're right on the cusp, changing your start and end dates by just a couple of days in either direction can get you over that bubble. Number one is protect patient health information. We've already talked about this. This is your privacy and security audit. You need to be doing this every year. The first year you do this is very difficult, and I understand that. It is a long process, and it's something that takes me a couple of months' worth of meetings to get through with most of my clients if you do it correctly. You're talking with your vendors. You're making sure that you have your business associates agreements in order. You're making sure that you have encryption in place. You're making sure that you have password policies on your computers. You're doing a walkthrough to make sure that there's no passwords taped to walls or taped to monitors around your office. If some of these don't sound familiar to you, you may not be doing your privacy and security audit correctly, and you may want to give us a call to help you out. Again, this should be done during 2015. That's our recommendation. You may hear otherwise people saying that you can do it during 2014 if it wasn't used for your attestation in 2014. I think that's dangerous, and I wouldn't recommend it. So do it during 2015, and for 2016, I would do it early. So that's the first objective, protect patient health information. The second objective is clinical decision support. And this is not a new one. This has been out for quite some time with meaningful use. For 2015, you have to implement 5 CDS interventions, 5 clinical decision support interventions. And you have to implement a drug, and drug allergy during the entire reporting period. So that's very important to understand as well. It has to be in place on day 1, and you have to document that it's in place on day 1. The third objective is computerized physician order entry. There are 3 measures under this one. 60% of medication orders must be entered via CPOE. Notice that doesn't say anything about transmission. That's just entry of CPOE. 30% of laboratory orders and 30% of radiology orders must be entered via CPOE. The orders do not need to go to any of those for this measure. So this does not count transmission. It does not count anything except for the fact that these are entered. For electronic prescribing, this ties into the first option here. The 60% of medication orders ties directly into Objective 4, electronic prescribing. Of those 60% of medication orders that had to be entered, more than 50% of those have to be queried for drug formulary and transmitted electronically. Notice that queried for drug formulary, that used to be a separate measure under Stage 1 of meaningful use, and it is now combined into the electronic prescribing measure. Alternate measure on this one for stage 1 providers in 2015, it's a 40% measure, not 50%. So that does line up with the previous measures for stage 1. Number 5, health information exchange. This is when you when you refer a patient to another setting of care. That could be a hospital, that could be a nursing home, that could be another doctor or specialist. You must use your EHR technology to create a summary of care and to electronically transmit that for more than 10% of transmissions and referrals. Now, if you were stage 1, you can claim an exclusion for this because it was not required. But notice 10%. That's not a lot, and it certainly wasn't. It's not as much as you might expect, and it will go up in stage 3, by the way. But one thing to keep in mind. Could you mute that? There's somebody who's on. Could you please make sure that your line is muted, or it may be Wendy as well. Something to keep in mind is that faxing does not count as electronic exchange. You must send it out electronically Now, if you send it to a third party to send it out, you actually can then use. They can send out via fax, but you cannot. You must not initiate send using a fax. Number 6, patient-specific education. We've been doing this since the beginning of Meaningful Use, and what this means is that you have to be providing educational materials to patients that are coming into your office for at least 10% of all unique patients. Notice that that's patients and not visits, so that actually is helpful. But there's an exclusion on that. You can actually claim an exclusion on this if you were on stage 1, but we're not going to select this as a menu item. Now, that's interesting wording, if you were not going to select this as a menu item. Most people did select this as menu items for stage 1 and 2. However, CMS has stated that they do not need any documentation to say that you were not going to select an item as a menu set item. Don't game the system on this too much. This is something you've been doing pretty much all along. It's not too hard to meet, but if you aren't meeting it, you do get a mulligan only if you were stage 1. Number 7 is medication reconciliation. Again, this is something we've been doing since the beginning of Meaningful Use, and this is for more than 50% of inbound transitions of care during the reporting period. Now, what's interesting here is in years past, they used to say that it was going to be a transition, inbound transitions of care, or any time that the provider thought it was relevant to do a medication reconciliation. I still recommend that medication reconciliation be done as part of the triage process, part of the process for getting a patient registered for their visit, possibly with a MA. I do recommend that this be done on every visit if possible. And again, because this was a menu set item, if you were not going to do this as your menu set item in 2015, you may claim an exclusion on this if you were a stage 1 participant. Number 8, patient electronic access. This is one that's been kind of a crawl on people's side, but this is now becoming more and more important. The portal is now required technology in order to have a 2014 edition certified EHR technology. So you should have a portal, you should have it set up and be using it. It is now required for the patient electronic access objective that more than 50% of all of the patients seen during the reporting period be provided timely information about their visits. And by timely, they're very specific. They mean within 4 business days. Within 4 business days, they must be able to view, download, or transmit their health information. That does not mean that they have to view, download, or transmit 50% of the time. It just means it has to be available in the system for them to do so. If they never do it, that's okay. Well, kind of, because in 2015, at least one of your patients needs to view, download, or transmit their patient information. You need to get one of your patients to log into your portal and utilize it, just to show that your portal was up and running in 2015, 2016. In 2017, you need to have more than 5% of your patients utilizing that portal to view, download, or transmit information. But in 2015 and 2016, just one person has to do it. So that's a big, big boon. Now for measure 2, which is the one patient view, download, and transmit, if you were stage 1, you can still claim the exclusion for that measure. Number 9, secure electronic messaging. And what you have to do for 2015 is you simply have to turn it on and make it available. It doesn't have to be used. In 2016, and I realize this is about 2015, but you should be thinking about what's coming next year as well. In 2016, you have to have at least one patient send a secure message. And in 2017, again, 5% of your patients must be using this. So it's time to turn it on, and it's time to get your patients starting to use it through all of 2016 in order to reach that 2017 5% goal. And again, for stage 1, if you are stage 1, you can exclude secure electronic messaging. All right, that brings us to the final. I went from 9 to 9. That's wonderful. The final objective and measures, which is public health reporting. Again, we talked about this kind of at the beginning of the show here. There are 3 possible measures for this, and this is the one place where you don't have to meet all 3. For 2015, stage 1 eligible professionals must meet one of these. For 2015, EPs who were scheduled to be on stage 2 must meet 2 of these measures. And then it'll be 2 for everybody starting in 2016 and beyond. So immunization registry, this is with the state or local. If you have a local immunization registry, you have to be submitting for your reporting period. Remember, though, that just as in years past, you have to be working towards this submission, and there are very specific definitions as far as what that is. But the crux of it is that by the 60th day of the reporting period, you must have registered your intent with your public health agency for either this or the syndromic surveillance measure. So make sure, and we may be beyond the 60th day already for 2015, but if you've done it in 2014, if you had registered your intent in 2014, that does carry over to 2015. There is no need to re-register your intent. That is important, and CMS has been specific about it. So the second one is syndromic surveillance, and the third is a specialized registry reporting. This includes what was called out specifically before, which is the cancer registry. But if you have a specialty-specific registry, either at the national level or at the local level, then you can utilize that as well. Making sure that you document everything and they provide you with information. At the state level, I know that if you go to ohiopublichealthreporting.info, that's in the state of Ohio, or if you go to the Indiana or Kentucky Department of Health websites, there's specific information about how to register your intent for these measures. And in Ohio, just a little secret, for eligible professionals, Ohio is allowing you to register your intent for syndromic surveillance, but they do not anticipate being able to actually onboard people for syndromic surveillance probably for another 6 months to a year. So this may be a good way to get that second measure, even for EPs that may not be ready to go for syndromic surveillance. Do register with the state to show them how much interest there is. They've been very vocal about that. They want to know how much interest there is so they can assign resources appropriately.
Scott, I'd like to interject here for a second.
Please,
I know that,
go ahead.
Okay, so I know we're going over this rather quickly, and there's a lot to take in. But I would like to point out, especially in the specialized registry reporting, many practices, especially PEDS practices, you're currently already utilizing your asthma registry, and you're reporting to that, and you're already doing that work, and that would count. So I want you to think about what you're already doing in your practices, because very many of these things you're going to find you're really already doing this work. It's just a matter of thinking how to match these things together to show that you've actually met the objective.
Absolutely. Wendy, any other bits of advice for practices that are working towards any of these meaningful use measures? Anything that you've seen that I've missed?
No, I don't think you missed anything. I am going to make sure I will put in the chat box here my direct phone number and email. I know a lot of you already have it. But if you have things that we can't get to in questions today, or you have very specific things that you're going to need help going forward, I want you to feel free to reach out to us. We know that this has been a tumultuous year, and the rules coming out so late in the year and only being applicable for a certain period of time and then changing again at the beginning of 2016 has certainly caused an influx of concern, and we're well aware of that, and we're certainly here to help, which is what we're doing here and what we're going to do going forward to make sure that we can help you as best we can. So I think the biggest thing is to keep in mind that these are manageable things to complete, and that there's a lot of initials. I kind of think of it as a bit of an alphabet soup, and when you get into this, it can really feel a little overwhelming. But if you take it piece by piece, it really is very manageable to do. And like I said, you'll find that you're really already doing quite a bit of this work. You just need to be able to make sure that you've documented what you're doing, so in case of audit, you're covered.
Absolutely. All right. Wendy, we don't have your contact information on this slide deck for today. I will make sure that it's on the slide deck, though, before it goes out in PDF form. So when people receive this in their emails, they'll have a direct line to contact you as well.
Perfect. And like I said, don't hesitate to call. What I don't want is people who are just struggling. That's what Scott and I and the Health Collaborative are here for, is to try to help you, accomplish this in as less painful a way as possible. Absolutely.
All right. I do want to give a slide with some other resources. Please don't feel like you have to write down the small URLs, because I know they're awful long. I did provide one shortened URL at the top. That's the go.cms.gov. And that will lead you to a page which has all of this information on it. Most of the information that I used to source this webinar came directly off of this page and the documents that are on it. I'm just trying to summarize it down to a kind of a bite-sized format for you. But everything is on this 2015 Program Requirements page. It is a very good idea for you to go visit it. So if you're going to write down any of the URLs, and I'm trying to stall to give you time to at least write down that top one with the arrow, and do note that the D in the final part of the URL does have to be capitalized. The H and the C have to be lowercase. That is something to keep in mind. So be sure that you note that it's one lowercase h, 89, uppercase D, lowercase c, 5. That comes after the go.cms.gov. And it sure beats writing down the whole long URL that if you goof up one character, it's not there anymore. These will also be on the PDF that you receive, so if you're not getting it right now, please don't panic. All right. That was a 45-minute lot of information to be covered. So
Whirlwind.
Yes. And we're going to open up we're going to open up for questions. If you would please type in any questions. Am I stealing your thunder here, Lori?
No, please go ahead.
If you would type in any questions into the chat box, make sure it's sent to everyone or to send to if you would rather not be seen by everyone, but I'm going to read it anyhow, send it just to Lori McAleer or Sharon Trainer, as it is. So the first question, go ahead.
Our first question is from Stephen at TriHealth, and he asked, would reporting via OARRS count for specialized registry reporting? And that may have a name that I didn't say right. But
yeah, and Stephen, unfortunately, I'm going to have to look into that one a little bit and make sure that this one is, the specialized registry reporting is one of the more confusing measures that are out there, and I think that there's going to be a lot of latitude given because the whole point of this is to make sure that you're reporting with somebody. But I'm not sure if ORS specifically counts for this, but I will look into it and see if I can come up with an answer for you. We do have your email on here. If you would write that down for me, Lori.
Yeah, I have it. We'll follow up with them.
Yeah, we do want to make sure that we follow up with you. The only question we have right now, we'll wait a little bit to see if anyone sends any message, anything through. Again, there's Wendy's contact information. And if you do have any questions, again, do type it into the chat. So what are the exclusions you can take on the last measure with regards to public health reporting? This is from somebody here at the Health Club, from Kelly. We do not report to registries, syndromic surveillance, or immunizations. Oh, that's actually an excellent question. So for these measures, you can be excluded if during your reporting period for immunization, if an EP did not, if an EP does not administer any immunizations, or if the immunizations that they collect are not collected by their local or state public health agency, you can take an exclusion. You can also take an exclusion if there's no immunization registry in your state, which in this area you can't take that one, or if they're not capable of accepting you at the start of your EHR reporting period. And the start of the reporting period is really the crux of the matter there. If they come through on day 90 of your reporting period, you're not expected to go forward. It really is on the start of your reporting period. So I would go out to the Ohio Public Health Reporting.info if you're in the state of Ohio, or if you're in Kentucky or Indiana, go out to your state's public health website and make sure. If you search for Kentucky Immunization Registry, Department of Health, that should take you right to the page if you Google that. Let's see. From Scott Mash. Scott Mash actually came back with an answer for ORS reporting. Thank you, Scott. He's with the Ohio Health Information Partnership, also known as CliniSync, which is the other health information exchange in the state. We work very well with them, by the way, and they're great folks up there. They checked on ORS reporting via ODH and OBOP, and they will not count as a specialized registry for 2015 and 16. That may change, however, for 2017. And Randy's asked for a link to the register for a hardship exemption. I will include a link to that, but the link to that should also be available off of the 2015 program requirements page. But I will make sure that is called out specifically in the information packet that we send out that you'll be receiving within the next 2 days or so.
Yeah, keep in mind, I had that on my list for Randy as well, but you want to make sure that you're not filing a hardship, although I suppose at this point you may be okay. I didn't know if you were even able to do that at this point, or you needed to wait until January when they open up for attestations after January 4th to be able to file for that.
That has been the case in years past, and typically you have a July deadline in order to do that. So we'll follow up with Randy to make sure that that's answered.
Right.
But that's actually a great point. If for some reason you are not able to make meaningful use this year and you want to avoid the payment adjustments in 2016 and 2017 if it's your first year of meaningful use, or just in 2017 if it's a continuing year of meaningful use, you can apply for a hardship. And this would be for something that is completely out of your control. Your vendor, for example, not being able to get you 2014 edition certified EHR technology, or there being multiple bugs in your system. These are evaluated on a case-by-case basis. Just because you apply does not necessarily mean that you will be granted a hardship. But when you're talking about your Medicare reimbursement being docked a few percent, it's worth at least a try.
So I'd also like to point out that one of the things that you'll want to keep track of throughout the year is if you have updates to your system, which you're bound to have, and they come back and it affects your reporting modules so that they're no longer accurate, or you're getting a lot of issues where, the documentation that you see is not reflective of the work that you're doing, or, an update just has a glitch in it. If you continue to make sure you keep track of your emails and your documentation so that if something happens and you try to do, meet meaningful use throughout the year, and some of these things make it so that some glitch in your system that simply was definitely out of your control, that you have the ability to document that in case of an audit, or if you do file for hardship. I've seen practices that thought they were going to get there. Something happened at the end of the year that was, absolutely, no fault of their own, but they didn't document anything or didn't have any record of anything, and so it made it difficult for them to be able to prove the hardship. So as your year goes along, as you're seeing these things, keep track of your notes and, just keep them in a file, keep all of that, so that if something happens and you need it, you have that as a backup.
I always say be sure to file all of your emails in a folder in your email system, or to print it and to keep it in a hard copy as proof that you were working on these issues throughout the year. One of the things that I've seen happen is that CMS will say, well, yeah, this was a bug, but what did you do about it? Did you report it? Did you try, what did you do to apply pressure to your vendor? And so the auditors can be very specific in their needs, and if you don't meet their needs, ultimately they are the arbiters of whether or not you're going to be receiving your meaningful use dollars. So do make sure that you document. I don't see any other questions. We'll keep watching as I kind of go through the next slide, and if something does come in, by the way, if something does come in that isn't answered, or if something is emailed to me or to Wendy or to Lori that has general applicability, we'll be sure to include it in the packet of information that we send out. We do want to make sure we provide you with the most information that we can. So here's what happens next. So
as Scott had mentioned, we will be sending a follow-up email, and again, that will contain a PDF of the slides from today, and we'll also include some other resources, including the Meaningful Use Measure Summary, and we'll include a link to register for our January 14th class. I know some of you have already registered for the January 14th class. It is an in-person class located at the Health Collaborative's offices in Norwood. It goes from 9 to 12, and it's on January 14th. So it will just provide a deeper dive into what we covered here today. In addition, it will tell you about how meaningful use fits into current and upcoming healthcare payment reform efforts. Again, we'll give a deeper dive into modified Stage 2 measures with a special focus on documentation needs for each measure, strategies and processes necessary for a successful privacy and security audit, and what you need to do and know in order to survive an audit, which hopefully none of you ever have to experience that.
Well, and although I agree with that hopefully no one does, but I know that some people on this webinar have experienced an audit, and we are seeing more and more practices being called for audits. And also remember that you can be called for an audit up to 6 years after the date of your attestation, so keep your documentation.
Yeah, great point, Scott. The other thing is that during the January 14th class, we'll talk about upcoming Stage 3 meaningful use and what you should be doing now to prepare for this next step. So Scott and Wendy will be our presenters. So again, if you haven't registered, we'd encourage you to join us. It should be great.
And there'll be a link included in the materials that you'll receive after in just a couple of days.
Yep.
Well,
I just want to interject one thing. First of all, I'd like to thank Scott for doing such a great job and all of you for joining us today. And I'd really like to point out, I know it's a hardship to, you're all very busy, and it's a hardship to take a half a day and leave the practice to be able to concentrate and do these things. But I really think it can make a huge difference in the amount of effort that you have to put forward throughout the year going forward in 2016. So if you're on the fence about attending the course in January, really try to push to make that happen. I think it'll be well worth your time.
Thanks, Wendy. Wendy, thanks for joining us today. As always, I love hearing your input from the field, and you always catch me when I goof up, so I appreciate that too.
And anytime, Scott.
All right. Well, with that, I'll give you back a couple of minutes of your day. Thank you, everyone, for joining us. My information is on the screen. Lori's is also on the screen. You can contact Lori for registering for the class. She'll make sure that you get the information you need. And we'll make sure that Wendy's is on this when it goes out as well. My apologies for leaving you off, Wendy.
No problem.
Thank you all again Thank you all for attending. Enjoy your afternoon.
Thank you very much.
Okay. Bye-bye.